Hello, I'm so happy to be with you today. My name is Nora Fritz. I am an associate professor at Wayne State University in Detroit, Michigan, coming to you from a rehabilitation perspective in my role as a physical therapist and a researcher. Today, I'm really excited to speak with you about the development and implementation of clinical practice guidelines for exercise in persons with Huntington's disease. Our funding acknowledgements are here as part of the development of this clinical practice guideline. We were supported by the Huntington Study Group, the European Huntington's Disease Network, and the Griffin Foundation. And as a part of this work, we've been able to, as a group of physical therapists and occupational therapists, travel to meet in person, albeit before the COVID pandemic. The agenda for today's talk is to talk with you about the development of these clinical practice guidelines and then what we're doing to implement them now. So the first question we often think about is why exercise? And exercise and physical activity have gotten quite a lot of attention in the last 5 to 10 years for people with HD and also for others with other neurodegenerative diseases, including Alzheimer's disease and multiple sclerosis and Parkinson's disease. And what we know from the research is that exercise can play a really crucial role in both the management of symptoms, and it may also have an effect on the progression of the disease. Certain types of exercise, like aerobic exercise, may even have a neuroprotective effect that slows the progression of the disease. Really like this quote from Dr. Robert Butler, the founding director of the National Institutes of Aging at the NIH, who said that if exercise could be packaged into a pill, it would be the single most widely prescribed and beneficial medicine in the nation. So we know that exercise has a range of benefits, from improving cardiovascular fitness, reducing cancer risk, and even improving mood, cognition, and motor function. But we also recognize that exercise is really difficult to do. And that includes getting motivated to exercise, knowing what exercises to do, and also how to progress those exercises over time and modify them for a patient's ability. The clinical decision-making about physical therapy treatment for individuals with rare neurodegenerative diseases like HD can be really challenging because there's not a lot of evidence available. And so it's likely that the studies that are available in these rare disorders use small sample, pre-post, or quasi-experimental designs. And it's common for clinical practice guidelines to draw on results from these more larger scale randomized controlled trials to make actual recommendations. And so in the rare disorders like HD, a wider representation of designs is really needed, because when a physical therapist or an occupational therapist who isn't seeing patients with HD every day encounters someone with HD, it's really quite helpful for them to have a recommendation or a guideline on how to best care for that patient who's sitting in front of them. So the development of the clinical guideline included a systematic review of intervention studies, the development of the clinical recommendations from what we found in the systematic review, and then now in this implementation phase, the development of clinical decision trees, which includes recommending outcome measures and also interventions. So first, we'll start with our systematic review of intervention studies. The evidence supporting exercise and physical therapy in HD has been growing over the last 20 years. Back in 2002, there were just a couple of studies available, very small studies, case reports, and one systematic review. But over time, we are moving toward many more randomized trials, many more pre-post trials available. So with these many different designs, it was important for us to choose a method for the systematic review that could take into account all of the available evidence. So we chose to use the Joanna Briggs Institute model. And this model has a couple key components. The evidence generation component includes the conduction of the research and the consultation of experts. And the evidence synthesis component includes conducting a systematic review, summarizing the evidence, and developing the clinical guidelines. And then we move toward more the evidence transfer and implementation that I'll speak about later in this talk. In the evidence generation phase, we wanted to include a wide range of study designs. That includes not just those randomized controlled trials that are at the top of our research pyramid, but also pre-post designs, prospective and retrospective cohort studies, case control studies, and even cross-sectional studies. And we were also able to include qualitative reports. So looking at the patient, family, and carer experience and perception of physical therapy and exercise. What are the perceived barriers? What are the facilitators? And how can we encourage success in our patients? For the evidence synthesis, the JBI has standardized extraction tools that allowed us to really standardize this process by study design. So there are specific tools for qualitative assessment, specific tools for meta-analyses, et cetera, et cetera. So we used all of these JBI tools. The JBI also, as part of the data extraction and synthesis, we can summarize the findings into different levels of evidence. So we talked about our pyramid of evidence. At the top, we have the experimental studies with level 1A being a systematic review of randomized controlled trials, for instance, or level 1C, more likely what we would find in this study, randomized controlled trials, all the way down to level 5 expert opinion. So ultimately, our findings are published in a 2017 paper from the Journal of Huntington's Disease. This is our systematic review. It's a mixed method systematic review. It resulted in both quantitative and qualitative studies. And combined, these papers assessed more than 440 study participants. Interestingly, 14 of the 20 studies that were included were conducted in Europe, 3 in Australia, and 3 in the United States. And to illustrate our earlier point, 17 of the 20 studies that were published between 2013 and 2016. So you can see that the evidence is really growing as we move toward the present day. This systematic review provided preliminary support for the benefits of exercise and physical activity to improve motor function, gait speed, and balance in people with HD. Looking at the qualitative findings, we can see that exercise is beneficial. So both individuals with HD and their caregivers perceive exercise as beneficial. And that's both from physical benefits of walking and balance, but also social benefits. So improving self-confidence and socialization. Individuals with HD and their caregivers also reported several facilitators and barriers, which you can see listed there. And the key take-homes here are that exercise really can be tailored to enable participation by individuals with HD and to address HD-specific impairments. The big barriers like lack of motivation, poor balance, and cognitive impairments that could impact success with rehabilitation really can be overcome by maximizing the facilitators, namely individualizing the training plan and identifying that committed caregiver or person who's going to keep the person with HD accountable and motivated and participating in the exercise program. That will ensure the success, and that's critical. The next step in the development of the clinical guidelines is the development of recommendations that can be easily implemented in a clinical setting. So we took those results and developed clinical recommendations, and these clinical practice guidelines are really just statements that include recommendations that are intended to optimize patient care. They're often informed by a systematic review and of an assignment of the level of evidence. And it also includes an assessment of the benefits and harms. So rather than dictating a one-size-fits-all kind of approach to patient care, the clinical practice guidelines offer an evaluation of the quality of the relevant scientific literature and an assessment of the likely benefits and harms. Establishing clinical guidelines is considered critical in physical therapy practice for decreasing unwarranted variations in practice and decreasing that gap between what's been published in the literature and what's actually being done in the clinic. So over the last few years, there's been many CPGs or clinical practice guidelines being published. More than 250 are listed on the American Physical Therapy Association website across various practice areas. Over the last several years, there's been more, specifically in the area of neurologic physical therapy. You can see a few of them listed here on the slide. The components of this clinical guideline include first, identifying the best available evidence, which is what we did through the systematic review process and the recommendation levels. The recommendation levels include a grade, this is the Joanna Briggs Institute levels, a grade of either A, which is a strong recommendation where it's clear that the desirable effects outweigh the undesirable effects, or a grade B, a weaker recommendation. where it's not clear if the effects outweigh the undesirable effects. And there's some evidence to support it, but it might not be the highest quality, so not up there with those randomized controlled trials. So at the time that we were developing these recommendations, it had been several years since we had conducted our systematic review. So we conducted another one, and we were able to add 5 additional quantitative studies and 1 additional qualitative study to our list of studies that were included in the recommendations. And we used this JBI approach to grade the strength of the recommendations for all of these studies. Ultimately, our clinical practice guideline was published in the journal Neurology in early 2020. And this infographic displays the main results. We have grade A evidence to support aerobic exercise that is delivered at 55 to 90% of heart rate max 3 times a week for a minimum of 12 weeks to improve fitness, which was measured by VO2 max, and to stabilize or improve motor function on the UHDRS. There's also grade A moderate evidence that one-on-one supervised interventions by either the therapist or the caregiver that are focused on walking and gait for at least some portion of the therapy session can lead to improvements in the speed of movement and some spatiotemporal measures of walking. A moderate grade of evidence, that's grade B, supports the use of exercise to improve balance in people with HD. We also have grade B evidence that regular breathing exercises delivered with or without resistance can improve respiratory muscle strength and cough effectiveness in people with HD. And we have limited and even insufficient evidence, because mostly based on expert opinion, that interventions to improve things like secondary musculoskeletal changes in posture or even end stage care are effective. But again, that's based mostly on expert opinion. As you can see in the infographic, we utilize some of our qualitative results here as well to make the statement that caregiver education is critical for maintenance of activity. The second piece of the clinical guideline is really incorporating the clinician's knowledge and skills. And we did this through soliciting healthcare provider input and developing a patient-client management model that were incorporated into the clinical guideline. The management model looks like this, and it just really demonstrates how the clinical recommendations might fit into the clinician's decision-making for individuals with HD. So at 12 o'clock at the top, you see the physical therapy exam and eval that says normal. The next step would be to determine those individual barriers and facilitators to exercise and develop prognosis and diagnosis that account for disease stage. Work with the individual to set goals and expected outcomes. And then here is where the recommendations come into play. Determine the interventions following the appropriate clinical recommendations, and then evaluate outcomes and start again. The final piece is incorporating the patient's wants and needs. And we did this through soliciting stakeholder input from persons with HD and their families, as well as healthcare professionals, including PTs and neurologists who regularly treat patients with HD. And all of their feedback was incorporated into our final clinical practice guideline. The last step that we're working on now is this implementation piece. And we really wanted to facilitate knowledge translation and implementation. So that is taking this published document and getting it into clinical practice. And so we're developing these clinical decision trees that link outcome measures with recommended interventions to make it a little bit easier in the clinic to understand when a particular intervention might be appropriate. So in understanding what outcome measures to recommend, the challenge was that there were very few specific disease-specific assessments for HD, and this is common across the rare disorders. We searched the literature to select studies that had evaluated the psychometric properties of different assessments in HD, and we extracted all of the sensitivity, validity, predictive capacity, all of the psychometric data in order to make these final recommendations. We classified the outcome measures into different performance categories that would be aligned with the categories that we used in our clinical practice guideline. And so you'll see that as we move through. We also utilized the Academy of Neurologic Physical Therapy's core set of outcome measures and took those into account in our determination of the final recommended measures. So this process has been evolving over time. In 2010 to 2012, the Academy of Neurologic Physical Therapy released what they call EDGE documents, which were specific recommendations for outcome tools in different diagnoses. And there was no HD EDGE document. In 2018, a core set, a clinical practice guideline of all assessments for neurologic physical therapy was released, but no Huntington's disease studies were included in that CPG. Our guidelines were released in February of 2020, and we met shortly after to start thinking about what outcome measures should be used in this population, which included the search of all of those HD studies as well as in other rare disorders. And as of right now, our manuscript is under review for this. Oh, okay. So what we ultimately find, as I mentioned, the outcomes are classified by these performance categories that are relevant to the clinical practice guideline. And the first category is exercise capacity and physical activity. And so you can see the range of measures that we considered, looking at what the recommendation is for that measure, what is the test-retest reliability and minimal detectable change, looking more at responsiveness. And ultimately we decided and came to the conclusion that the 6-minute walk test was the appropriate measure for this category because it had been tested in HD before and had established psychometric properties. Next was the category of mobility and function, and you can see a range of different measures there. And ultimately, we recommend the timed up and go for assessing balance and mobility and fall risk in early to mid-stage HD. You can see that there's a fall risk cutoff established for the TUG in persons with HD. Next, the balance and fall risk category, where you can see that the final recommendation is the Berg balance scale, which aligns nicely with the core set of outcome tools. We also have fall risk cutoffs available for the Berg. And for respiratory function, the 6-minute walk test again. In the secondary musculoskeletal and postural change category, the Berg balance scale was the recommended measure. And finally, in end-stage care, we recommend the use of the SF-36, which is a quality of life measure. So if we summarize this into a core set of clinical assessments for persons with HD, it comes out to just 4 measures: the 6-minute walk test, the timed up and go, the Berg balance scale, and the SF-36, which would allow you to assess across categories any impairments that the individual might be experiencing. And from there, we then propose the use of some algorithms, clinical algorithms, which I'm showing here, with both a physical therapy evaluation, where we start with the history and review of systems, move down to looking at 3 major categories of the primary goal for the patient being prevention or wellness, the improvement of mobility, and addressing issues that are secondary to immobility. We then suggest the use and examination of the core set of measures for persons with HD to determine the primary movement classification, determining barriers and facilitators, and then proceeding to the plan of care. The plan of care algorithm you can see here, where the plan of care is focused mainly on exercise capacity, mobility, balance, or posture, and then or respiratory function, postural control, or end-stage care. And we move forward then to develop individualized goals and plan of care that meet the particular needs of that person. Of course, that can be implemented, adjusted, or progressed using the recommended interventions that we propose in our paper, monitoring for adverse events, and then if moving back to the beginning of the assessment if needed. So in summary then, there is some emerging evidence to support physical therapy interventions to improve fitness, motor function, and gait in persons with HD. It can serve as a model rare disease to demonstrate the importance of clinical practice guidelines, which provide clinicians with easily adaptable and scalable interventions to use when encountering patients with rare diseases. I want to thank you for your time and attention. I'm excited to speak with you in person and answer any questions that you might have. Thank you so much.